I'm joining you guys from sunny South Jersey. And I'm going to talk to you today about the treatment of the spastic equinus neuromuscular foot. So I've heard a lot of these talks. They're wonderful and they're great and they're very, very high tech. So I'm going to change the gears a little bit. I'll probably get you guys back on track in terms of time. And I would say this is a lot more of a low tech solution, but it's a lot more common of a thing than some of the things that have been presented so far. I don't have any financial disclosures in terms of really anything, but this talk specifically. So, about a couple of weeks ago, Dr. Marcellet asked me to describe neuromuscular, orthopedic stroke care. And so I kind of, went a little bit and said, well, I don't think I can do that, but I think I can explain one aspect of it. And it is actually a very common aspect that we treat. Probably like something like 50 to 60% of people that come to see me are coming for some type of a foot type of intervention. And for good reason, because it's very, very common in strokes and brain injuries to get a neuromuscular club foot or spastic equinovarus foot, as they call it. And it's extremely disabling. And a lot of times patients will have the ability to ambulate, transfer, that sort of thing, if it wasn't for the foot deformity. And, we see lots of very, very heroic efforts on the part of physiatrists and orthotists and to sort of accommodate for these things. But, there's some simple orthopedic procedures that take less than an hour that can basically bail a patient out and get them back on track and get their rehab ready to go without much difficulty and with a very, very low complication rate. So basically, in order for this talk, I'm hoping to teach the audience how orthopedic surgery can treat or be an adjunct to treatment of spastic deformities of the foot and ankle, and identify specific pathologies that can benefit from surgery, and basically to know when referral or surgery is recommended or indicated. So to start out with, orthopedics basically is a discipline that was named after scoliosis, basically, and it means straight child, or you could say straight foot is another way to say it, but straight child is what it's meant to be. And you can see our symbol of orthopedics in Philadelphia is the crooked tree, but instead of with a rod, it's with a cheesesteak. And it's a surgical discipline that's basically focused on the restoration of function. And I would say it's got significant synergy in terms of rehabilitation disciplines. Without rehabilitation, orthopedics really can't exist, and without orthopedics, rehabilitation doesn't function as well. And I would say the best interventions are often very simple ones, which can restore anatomy and can have profound results if applied with care. So what can we do with surgery? So we can basically remove obstructing tissue. We can replace or fuse damaged joints. We can transfer force from one place to another, and we can correct bony and soft tissue deformities quickly and permanently. So in terms of the principles that we use as guiding principles, we like to generally operate early before deformities get fixed and rigid, because it allows for a simpler surgery that allows the patient to get back on their feet more quickly. It's very, very important to distinguish between the function of the limb and the function of the patient. You may not be able to restore active function in a patient, but by lengthening some muscles, you can still make it much easier to take care for them, much easier to get dressed, that sort of thing. And so you can have profound results in their day-to-day life, even if you don't restore any active function to them. Spastic muscles are weak, so it's important to know that in advance of when you're trying to treat the patient, because you need to get the diagnosis correct in terms of the length of the muscle, so that you don't over-lengthen or under-lengthen a muscle too much. You want to keep the rehabilitation in mind. The surgery is done in the settings of the patient's overall clinical picture and rehabilitation goals. So I might do one of these spastic neuromuscular foot surgeries when a patient is in acute rehab, even though that I know that they're in their spontaneous recovery phase, because I know ultimately the surgery is not going to hurt them, and it might help them in their early going, which may ultimately lead to a faster recovery. And I would say muscles don't know why they are spastic. Many of the principles will be the same across a variety of pathologies, but that natural history of the problem, and so the plan may vary slightly. So now on to the more specific things relative to the foot. The most common thing that we see is equinus spasticity or contracture. It's extremely common. It can happen after trauma. It can happen as a result of a stroke or a brain injury. It's one of the most common referrals I get. And probably because it's a little bit more difficult to manage than some other contractures with PT and pharmacologic measures, because the lever arm that you're stretching off is very, very short. So all the lever arm you have to stretch off of is basically the length of the foot. Whereas if you're trying to stretch out a knee flexion contracture, you have the whole length of the tibia to work with. And so I think stretching and casting, it makes it difficult. Serial casting, you run the risks of heel sores and skin breakdown. So surgery tends to be the treatment of choice with a lot of these things when other more simple interventions have failed. I have a picture of the silver skull test. The gastroc soleus complex is basically two muscles. The gastroc muscle crosses the knee and ankle, whereas the soleus only crosses the ankle. And so by checking the degree of equinus with the knee straight versus with the knee bent, you can tell the difference between equinus as a result of both the soleus and the gastroc, or just the gastroc. So, you might decide to do a lengthening of the muscle in the back of the leg. And there are zones involved here. And so I would say the rule of thumb is the more distal you go with your lengthening, the more correction that you can get, but the more potential weakening you can have. The more proximal you go, the less weakening that you'll have, but the less correction you'll also have. So if you look at this picture over here, you can see like the different zones that we can talk about. Whereas the first zone is where you're going to do your teno Achilles lengthening with like your Hoke or your White lengthening, where you're just getting a non-selective lengthening of the Achilles. It's the most powerful method, but it also leads to the most weakening. And in some disorders like cerebral palsy, it can actually lead to calcaneus or crouch gait. Superficial with the more zone 2 type of lengthenings with a Vulpius or Baker, it's a non-selective lengthening, but it's weaker. It's more of like a recession of the common muscle tendon junction. And so you lengthen both muscles, but it's less aggressive, and so you're less likely to overcorrect the deformity. Or then you could do a strayer, which is basically you take the gastroc muscle off the soleus fascia and do a slide, and you just lengthen the gastrocnemius only. And that would be as if your silver skull test showed that you had equinus only with the knee straight, but not with it bent. Zone 4, when you're talking a Bowman recession, you're just getting a sort of a reduction of the spasticity by muscle lengthening, but not much length in terms of the overall muscle tendon junction. And it can indirectly reduce tone by inducing some small amount of passive insufficiency of the muscle. It should be noted that when you lengthen the gastroc muscle, you can get modest correction of knee flexion as well, because the gastroc crosses the knee. So in terms of like aggressiveness, you have your Gastroc recession, which is kind of the least regressive lengthening that I do. A common recession, which is a slightly more aggressive. It's kind of my workhorse for this. And then the teno Achilles lengthening for patients that are lower demand but need much more correction. Post-operatively, we generally make them weight bearing as tolerated, and it's about 4 weeks in a cast and then rehab. The next most common thing is going to be a varus deformity. So when you think of a spastic clubfoot, it's usually equino-cavo-varus. So varus refers to the hind foot. It's multifactorial. It can be primarily resultant from muscles in the posterior medial ankle, which would be the tibialis posterior and toe flexors, which would lead to more isolated hindfoot varus, or it could be the tibialis anterior, which would lead to varus and forefoot supination. And it should be noted that the Achilles tendon will result in a deformity in whichever direction the foot is already going in, because when the foot's already in varus, the pull of the Achilles will be medial to the center line of the leg, and so it'll pull into varus. Whereas if it's lateral, then it'll pull more into valgus. So if you see a planovalgus foot, you're going to have the opposite issue with the Achilles. Toe flexors can also contribute due to their posterior medial position on the ankle. So in terms of the hindfoot varus treatments, a simple procedure would involve soft tissue. So if it's passively correctable, you're going to consider a splat, a tib post recession. And generally speaking, for like the vast majority of patients with adult neuromuscular clubfoot, this is what they're going to get. And if they've already been walking, but they're doing the procedure to walk better, I'm more likely to leave it a little bit undercorrected and do some of these osteotomies, because particularly if there's significant weakness, because it takes a lot longer for these patients to recover due to their underlying condition. If there's moderate varus that's fixed, you might consider a calcaneal sliding osteotomy. It heals extremely well. Some people will even weight bearers tolerate it on it immediately, although I don't. And then if it's a more complex deformity, you can consider a triple arthrodesis. Differences are in postoperative rehab protocol and also potential complications, swelling, that sort of thing. So in order to figure out what to do, you can do you're going to rely on physical examination tests. Some people will do a gait lab, although we've done less of these recently because the answer tends to be the same most of the time. You can do a confusion test, which is basically you have the patient flex up their hip. And what'll happen is if the tibialis anterior is involved primarily, they'll get a supination as they flex up their hip as part of a mass activation. You can also feel the tibialis posterior, although I have a little bit more trouble with this, particularly if the patient is heavier. And so often I'll decide to do a tibialis posterior recession based on the way the foot looks intraoperatively after the Achilles tendon lengthening is done. And then in order to figure out if your forefoot is driving your hind foot, you can do something called a Coleman block test, which is basically you put a wood block underneath the lateral aspect of the foot while allowing the first metatarsal to drop off of the block. Now, if the varus goes away, that means the forefoot is driving the hind foot. Possible interventions for that include a recessed first metatarsal head orthosis with a lateral hindfoot post, or you can do a plantar fascia release, Jones transfer, first metatarsal osteotomy. If you see that your Coleman block test is still in varus when you do your Coleman block test, that means the hind foot is fixed, and you're likely going to need a calcaneal osteotomy instead. In terms of the tibialis posterior, we usually want to do an intramuscular recession. You want to try to avoid a distal tenotomy because you can end up with the opposite deformity down the road. So, the incision is typically one of my hands breadth above the medial malleolus, which usually works out to be 5 to 6 centimeters. You assure that the underlying muscle belly is present, so you make sure you don't do a complete release. And I usually do this if the foot doesn't sit neutral after the teno Achilles procedure. So the workhorse of this whole thing is called the split anterior tibialis tendon transfer. Basically, you make an incision directly over the tibialis anterior. You split the tendon into 2 equal halves. And then you make an incision further up so that you can split the tendon, and then you bring it down to the cuboid and fix it with an interference screw. This is the most reliable way to do it. Provides an instant fixation of it. When the foot's in a lot of equinus, it tends to leave the opposite side on slack. I don't usually worry about that if it's an older person. If it's a very young, active person, I might stick it down to the navicular using a metal suture anchor. But I do that rarely, once out of every 5 to 6 cases, maybe. Post-operatively, the patient's in a cast for 6 weeks, which we typically change at 2 weeks to make sure the cast is well-fitting. And then 6 weeks with a boot or a brace after that, and then PT after that. And finally, you don't allow into stretching into equinus or varus, which typically physical therapists do not end up wanting to do anyway, but it's something that we mention on our physical therapy prescriptions. A calcaneal sliding osteotomy is done for deformities which do not correct with soft tissue lengthenings. We make an oblique lateral incision. We use an oscillating saw and finish with an osteotome. You slide the heel osteotomy laterally, and then you fix with a compression screw. Generally speaking, we will leave the patient non-weight bearing for 4 weeks, split for 2 weeks. And I would say it's rarely necessary in adult neuromuscular feet. They actually have new implants, including staples, but I think a screw works really well. They actually have nice screws where the head is also threaded, so you can leave it buried underneath the bone and it's not symptomatic. Triple arthrodesis is for severe and rigid hindfoot deformities where you can't get it plantigrade with anything less. And you still need to correct the cavus if it's present. Otherwise, you'll leave it with corrected hindfoot and an inability to accommodate through the hindfoot varus. The downside is that you can get adjacent arthritis, adjacent sort of segment disease. And as such, it's considered to be a little bit less popular to do this. However, I would say that there's been studies, at least in the cerebral palsy population, that have shown that they don't take as many steps as neurotypical populations. And by making a plantigrade foot, you're doing them a lot better service than just leaving them undercorrected if it's going to leave them severely undercorrected. I would say create a plantigrade foot and they'll love you. In terms of foot and ankle spasticity, in terms of cavus, there are multiple treatments for it. Simple treatments include a plantar fascia release, and this will be enough for most adult neuromuscular. I would say the key difference between cerebral palsy and neuromuscular adults is that adults will have normal motor programs. They usually don't have bony deformity because they've had a chance to develop normally, and then they've had their neurologic insult later in life. Whereas cerebral palsy will oftentimes need bony procedures. Adults will only need bony procedures if the deformity's been long-standing, which is why it's important to refer them early. Moderate deformities can be treated with a Jones transfer, which is basically a transfer of the EHL to the metatarsal neck, along with a plantar fascia release. And more complex deformities can include a first metatarsal osteotomy, which when done in concert with a Jones transfer can work really, really well, and patients really love it. You can do one or more of these things, and the differences are basically in post-op complications and rehabilitation. Although, to be honest, the incidence of complications is pretty low, assuming that your patient selection is good. Whenever you do an osteotomy or a fusion, you want to be careful of patients' smoking history, and also their diabetes status can interfere with their ability to heal the surgery. In terms of toe flexor spasticity, if it's mild and dynamic, it can be treated with a proximal FHL and FDL recession. If it's more severe, which is the more common case, you might need to do distal releases. We do FHL, FHB, FDL, FDB. They must all be cut or else they'll get boutonniere deformities. We usually do it percutaneously, but you got to make sure you get all three. If the joints are contracted, you have to consider a true hammer toe correction. But what my general practice is do the distal release of FHL and FHB and FDL and FDB, and then if they have trouble later on, I'll do a hammer toe reconstruction as the second surgery. And the reason I do that is just because you can get a dysvascular toe by doing a hammer toe correction, particularly if you've done a lot of work on the foot otherwise. So I found that after doing the neuromuscular clubfoot reconstruction, the foot's been through enough abuse, and basically you should just take what you can get off the distal release. Most of the time it's okay, even if it's a little undercorrected, patients won't mind. And in the few cases where you need to do the hammer toe reconstruction, you can do it down the line. So as far as a final word about these treatments for spastic equina varus, I would say it's important to remember that surgery should not be considered the last option. It's just an option. So if it's better for the patient, it's better to do the surgery rather than not to do it, and just to kind of work around less optimal treatments first if they're not working. Shared decision-making should be done with the patient and the patient's family, and the ultimate goal should drive what the treatment is. And the questions I always ask is like, will surgery assist in the short or long-term rehabilitation of the patient? And does the natural history of the disorder indicate that surgery would be the best treatment? And if those two, the answers to those two questions are yes, then surgery is the answer.